All right, let's dive right into the primary prevention of atherosclerotic cardiovascular disease. Now, if you're studying for the PEBC exam, you're going to want to pay close attention. Think of this as your high-yield study guide. We're breaking down all the key concepts, guidelines, and clinical pearls you absolutely need to know.
So here's what we're going to cover. We'll start with the basics of prevention, then walk through how to assess a patient, cover lifestyle changes, and then dig into the core drug therapies. We'll wrap it all up with some key takeaways. It's a really logical flow that pretty much mirrors what you do in a real clinical setting. Okay, first things first. To really build a solid understanding here, we have to start by defining what we're even talking about. What exactly is primary prevention, and what are we trying to accomplish? So, here's the absolute crucial point. Primary prevention is all about being proactive. The key word is prior. We're stepping in before a patient has a heart attack, before they have a stroke, before any of those clinical events happen. It's all about stopping the disease process before it rears its ugly head. And these are our goals, right? This is our North Star. Every single decision we make, whether it's suggesting a diet or writing a prescription, is aimed at hitting these four targets. It's a balancing act. We want to prevent the bad stuff, but we also have to make sure our treatments aren't causing more harm than good and are actually helping people live better lives. Okay, so we know what we're trying to do. Now let's figure out who we're doing it for. This section is all about the process of assessing our patients, identifying who needs our help the most, and, really importantly, figuring out their specific level of risk. You have got to know this table inside and out. It's fundamental. It splits all the risk factors into two big buckets: the stuff we can change, the modifiable factors, and the stuff we're stuck with, the non-modifiable ones. For your exam, knowing what goes where is critical, because our entire strategy revolves around hammering those modifiable risks. And it's not just about the classic factors anymore. You also have to be aware of these emerging risk enhancers. Things like inflammatory diseases, HIV, or chronic kidney disease. They all independently crank up a patient's cardiovascular risk, and we have to factor that into our assessment. Okay, get your highlighters out for this one, because this slide is pure exam gold. For diabetes and lipids, lock in that starting age, 40. And know the frequencies, every 3 years for diabetes, every 5 for lipids. But also really pay attention to those high-risk features that would make us screen someone earlier. That's prime material for tricky exam questions. And here's the big picture rule you just have to memorize. For pretty much anyone walking around between the ages of 40 and 75, we need to be calculating their global cardiovascular risk at least every 5 years. It's a key guideline, plain and simple. So once we have all that patient data, what do we do with it? Well, we plug it into a tool like the Framingham Risk Score. This spits out a 10-year risk percentage, and that lets us put patients into one of 3 buckets: low, intermediate, or high risk. And this, right here, is what determines how aggressive we get with our treatments. Lock this number in your brain, 20%. A 10-year Framingham risk score of 20% or higher means that patient is automatically in the high-risk category. These are the people where we're not just talking about lifestyle changes, we are strongly considering starting medications like statins. Now, before we even think about reaching for the prescription pad, we have to talk about lifestyle. This stuff is the absolute foundation, the cornerstone of every single prevention strategy for every patient, no matter what their risk score is. This is huge. I mean, think about it. While a lot of diets are probably good for you, the Mediterranean diet has solid, high-quality evidence showing it reduces actual heart attacks, strokes, and death. And a 30% reduction, that's a massive deal. It's a critical point for counseling patients and for your exam. And here they are, the numbers you just have to know. These are these specific targets from the Canadian guidelines. You got to memorize them. 2 grams of sodium, 150 minutes of exercise, the BMI range, the waist circumference cutoffs, and the alcohol limits. These give us concrete, measurable goals to work on with our patients. All right, let's get into the drugs. Because when lifestyle changes just aren't cutting it, or when a patient is already in that high-risk category, we turn to pharmacology. We're going to tackle the management of the big 4 here: high blood pressure, cholesterol, diabetes, and obesity. This table is absolutely critical for managing hypertension. You've got to notice the nuance here. It's not one size fits all. Look at how the thresholds to start treatment and the final targets change based on who the patient is. If they have diabetes, we start at 130/80 and aim for below that. But for a high-risk patient, we get even more aggressive with a systolic target of less than 120. Let's be super clear about this because it's a very testable point. When we're talking about primary prevention,
stopping that first heart attack or stroke. The evidence for improving actual outcomes overwhelmingly points to one class of medication: statins, period. So who gets a statin? Well, for high-risk patients, it's pretty much a given. But for that intermediate risk group, these lipid numbers are your triggers. If their LDL is 3.5 or higher, or if these other markers are up, that's when you need to have a serious conversation about starting a statin.
This is a simple but really profound concept. The second a patient gets a diabetes diagnosis, they're automatically considered high risk. You don't even need to calculate their Framingham score. The diagnosis itself puts them in a category that demands an all-out, comprehensive risk reduction strategy.
And this right here, this is a total game changer in how we manage diabetes. We're not just trying to lower blood sugar anymore. We now have two classes of drugs, GLP-1s and SGLT2s, that are proven to also protect the heart and reduce cardiovascular events. This is why they're often the go-to drugs for high-risk patients with diabetes. So what about obesity? Well, when diet and exercise aren't quite getting the job done, we do have several medication options available in Canada. But remember, these are always an add-on to lifestyle changes, never a replacement for them. Now, the SELECT trial is a landmark study, and okay, technically it's a secondary prevention trial since the patients already had heart disease, but its findings are practice-changing. This was the first time a drug mainly for weight loss was shown to also significantly cut the risk of heart attacks and strokes in people who had obesity but didn't have diabetes. It's a huge development.
Okay, next up, two huge topics. First, the super controversial role of antiplatelet therapy in primary prevention. And second, smoking cessation, which is, well, probably the single most important intervention we can ever encourage someone to do.
This table is fantastic for comparing the bang for your buck of these drugs. Just look at the number needed to treat, the NNT. To stop one major event, you only need to treat about 52 people with a statin. For aspirin, you have to treat 241 people to get that same benefit. It really puts the relative benefits into perspective.
And this slide tells the whole story of the aspirin controversy. Look at these numbers side by side. The number needed to harm to cause one major bleed is 210. The number needed to treat to prevent one event is 241. You're actually more likely to cause harm than to provide a benefit. That's the core of the issue.
So what's the bottom line here? The big takeaway message? Simple. We are not routinely recommending low-dose aspirin for primary prevention in most people anymore. The recent trials just don't show a net benefit. The days of everyone taking an aspirin a day are over. When it comes to smoking cessation, our best bet is always a combination approach. We want to use pharmacotherapy, things like nicotine replacement, bupropion, or varenicline, and pair it with behavioral support. And a really important point for your exam: e-cigarettes are not a recommended strategy for quitting. The evidence just isn't there.
All right, let's bring it all home. We're going to tackle supplements because you know patients are going to ask about them, and then we'll wrap up with some key therapeutic takeaways that you can use in your practice.
Sooner or later, your patients are going to ask about these supplements, and this table gives you the clear, evidence-based answer. For omega-3s, vitamin D, vitamin E, B vitamins, and multivitamins, the big studies have shown no real benefit for preventing cardiovascular disease. Look at the numbers. They're all non-significant. Think of this as your 5-step plan for having that conversation with a patient who feels perfectly fine. You start by acknowledging that. Then you use techniques like motivational interviewing to set goals. You frame the benefits in real terms, like preventing a heart attack. You stress that this is a long-term commitment, and you use tools to help them see the real risks and benefits for themselves. So I'll leave you with this question to think about. After going through all of this, the new thinking on aspirin, the specific diabetes drugs, the lifestyle targets, what's the one thing that will most significantly change how you talk to your future patients about their cardiovascular risk? Thanks for watching.